morning, everybody. My name's Umar. I'm a resident in orthopedics. Today I'll be giving a refresher on osteomyelitis. So osteomyelitis is an infection of bone and bone marrow characterized by progressive inflammatory destruction and apposition of new bone. It can be quite a varied presentation, and it's known as a great pretender. But in general, this is a condition where treatment is usually a combination of culture-directed antibiotics and surgical debridement of non-viable tissue. The way we think about osteomyelitis has been broken up by a couple of different classification systems. One of the older ones, the Wald-Vogel classification system, used to look at the timing of the infection, breaking it down into acute, subacute, and chronic. Acute being less than 2 weeks, subacute 2 weeks to a month, and then chronic being anything over a month, as well as by its sort of etiology in the pathogenesis, whether it's spread via blood or a non-hematogenous spread, so contiguous or direct inoculation of the bacteria. It has a fairly limited clinical value, as it's largely just about the etiology and does not inform in management. There's another major classification system that's thrown around, but again, this sort of clinical value and how we use it to direct our management isn't all that useful. It sort of breaks the classification down into the anatomical location of the infection in the bone, as well as the physiology of the host. So here's just a graph depicting where it's generally the long bones where this is talking about, where the infection is, and then the host type. There's a table that you can look up with different things such as nutrition status and immunocompetency of the host, and you can break it down by subtype there. And there are some sort of directions for management when you break it down by this Sioni-Maeder classification. So generally speaking, for an infection in the bone to occur, the infection needs to get in from one of two ways, either through the blood or by breaking the periosteum barrier to the bone. So the hematogenous route of spread is the most common way that a children gets osteomyelitis. It's less common in adults. In adults, the most common site for osteomyelitis by hematogenous spread are the vertebral bones, followed by the flat bones of the axial skeleton, like the clavicle and the pelvic bones. And this is where IVDU patients most commonly get osteomyelitis. And last on the list are the long bones of the appendicular skeleton. This is in contrast to children, where the most common site of hematogenous spread of osteomyelitis are in the long bones of the body, particularly at the level of the metaphysis, where blood supply is most rich. On the other side, you have non-hematogenous spread, so that can be further broken down into contiguous or direct inoculation. Contiguous spread usually sort of involves an infection in surrounding tissue that then sort of translocates into the bone, and the most common example of this would be diabetic foot infections. Examples of direct inoculation would be penetrating injuries or open fractures, as well as during surgical procedures where obviously sterility sometimes can not be maintained. Here's a table showing the most common organisms to cause osteomyelitis. By far and away, Staph aureus is the most common pathogen to cause osteomyelitis, both in kids and adults. In terms of pathogens, when you think about hematogenous spread, generally speaking, it's a monomicrobial infection, and it's usually Staph aureus, whereas the non-hematogenous osteomyelitis often have more than one microbe involved. They're polymicrobial. clinical presentation for osteomyelitis is quite varied. It can involve systemic symptoms as well as local symptoms. The systemic symptoms can be vague, from non-specific pain and low-grade fevers for months on end to high-grade fevers, weight loss, night sweats, anorexia. There's also local symptoms that can occur, like erythema, tenderness, edema, and restriction of movement at the site of the infection. And you can sometimes see a draining sinus, which is pathognomonic for chronic osteomyelitis. If you were to probe down into these sinuses, you would often be able to probe straight down to the bone. Investigations for osteomyelitis. In terms of laboratory investigations, the inflammatory markers are useful in helping us point us towards a diagnosis of osteomyelitis. Often the white cell count will be normal, but CRP is almost always raised in osteomyelitis. From an imaging perspective, X-rays are the first form of imaging that we use, but radiographic changes don't show up till at least 2 weeks, when about 50% of bone loss has occurred. In chronic osteomyelitis, you may see bone lucency, a sclerotic rim, osteopenia, periosteal reaction, and sequestrum, which is devitalized bone separated from surrounding bone and involucrum. CTs can also be useful more to sort of help aid in operative planning to show you where the necrotic bone is. And MRIs, probably the best test for diagnosing early osteomyelitis, and that shows up with increased T2 sequences showing bone and soft tissue edema. Here's some X-rays showing some examples of osteomyelitis. The first image shows us some sequestrum there, and possibly some periosteal reaction. The second image is an example of infection in the long bone. And the third image is a pretty classic photo of a diabetic foot causing osteomyelitis, where you can see bone lucency and loss of this sort of cortex there. In terms of managing osteomyelitis, first thing we can do is try and improve host factors to ensure that adequate healing can occur. The treatment is usually a combination of antibiotics and debridement. In terms of antibiotics, generally speaking, you need 4 to 6 weeks of antibiotics post debridement of necrotic tissue. If a patient has infected metalware in situ, they need to, generally speaking, be on antibiotics until that metalware is removed. And also, if there's a fracture associated, they need to be on antibiotics until the fracture is healed. From an operative standpoint, the first thing to do is address the soft tissues that's infected, so debride that away. And then similarly with the bone, the necrotic bone, you need to debride that away and debride until there's essentially a bleeding of the bone. It's known as the paprika sign. If there's hardware there that while there's an infection, it would be recommended to remove that hardware. But again, bony stability is important for the healing of this. So if there's a fracture there, you generally need to fix it. That's often with external fixation as a preference, but you can obviously do internal fixation if we need, and followed by dead space minimization. So in terms of fracture fixation, you can get antibiotic impregnated implants, which can help avoid developing a biofilm for the bacteria. And there's also things such as antibiotic impregnated acrylic beads to help fill dead space. It's also recommended bone grafts or local tissue free flaps to cover up the dead space to avoid infection accumulating. Those are the main principles for management, and that's my presentation on osteomyelitis.